Now we're going to see the flail chest. This is seen in chest trauma and is the result of more or greater than or equal to 3 rib fractures in at least 2 different points. So we have the ribs like this, and we need that they be broken at least 3 adjacent ribs, for example these 3, and in 2 points, so like this, and this is called flail chest. This will present as paradoxical movement of the of this part of the chest when the patient is breathing. So when we breathe in inspiration, the chest and everything like goes out in inspiration, and in expiration the chest goes inward. But in the paradoxical movement, or in this part, this flail chest, it does the other way around. When the patient does inspiration, the chest moves inward, and when the patient is doing expiration, the flail chest moves outward. So this is paradoxical movement. The true damage to the lung is because flail chest is associated with pulmonary contusion, because this is a severe trauma, so the patient has pulmonary contusion, and it's this that causes the pulmonary problem. And the management is usually with pain relief and physiotherapy, etc. We should be very, very careful in IV fluids. Sometimes we should restrict the fluid intake for the patients with pulmonary contusion, because the problem in pulmonary contusion is the edema for accumulation of hemorrhage or just fluid that produces a diffusion problem. Alright, so the patient also can have decrease in the inspiratory effort because of pain for the ribs that are fractured. So we should treat the pain of the patient. It's very important to treat the pain in order the patient that can produce a good inspiratory effort. And also the physiotherapy. These patients are usually treated with positive pressure ventilation, and the most common adverse effect of positive pressure ventilation is a pneumothorax. The thing that produces that the breathing of the patient is inefficient is that because there is this flared chest and the chest is moving the other way around, this is a paradoxical movement, we have lost the negative intrapleural pressure during inspiration, and there is increase in dead space. So for these 2 reasons, the respirations of the patient are inefficient, and we can do the positive pressure ventilation.